It's my sincere pleasure today to be with a wonderful group of panelists regarding review of some GI cancer cases. My name is Dr. Kathy Ng from Vanderbilt Ingram Cancer Center, the David H. Johnson Endowed Chair in Surgical and Medical Oncology, and the co-director of the GI Research Program. Today we have some wonderful panelists, and we'll just go around and have them introduce themselves. So please introduce yourself, Carrie Siegel.
Hi, good afternoon. My name is Dr. Carrie Siegel. I'm an abdominal imaging radiologist at Washington University in St. Louis.
Hello, everyone. My name is Al Benson. I'm a GI medical oncologist at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center, where I serve as one of the associate directors.
I am at Emory University and Winship Cancer Institute. My focus is primarily complex upper gastrointestinal and hepatobiliary surgery, and it's a pleasure to be here today.
I'm Preetash Patel. I'm an associate professor of radiation oncology at Emory University. I work closely with Dr. Kubi. Glad to be here today and to discuss some good cases.
I have a 70-year-old male now, non-smoker, borderline resectable pancreatic carcinoma, going back to more pancreas carcinoma patients, who has completed his neoadjuvant chemotherapy, has had a Whipple with positive margins and node-positive disease, and unfortunately has now developed recurrence reportedly while in adjuvant therapy. So his initial presentation was abdominal pain, constipation, and nausea. His ECOG performance status at baseline was 1. His medical history only includes some arthritis. Social history only includes some social alcohol consumption, no contributory family history. And Dr. Siegel, can you comment on his original imaging?
This is an arterial phase CT. And just to comment, the standard pancreatic protocol is non-contrast imaging, so we can later assess whether masses are enhancing. We have pre and post contrast images. Then we get arterial phase, which is really best to look at the SMA, the celiac axis. And then we like portal venous phase imaging to really get us our best look at the liver. So this is more of an arterial phase image. And there's a couple things going on here. You can see that about the SMA, there's soft tissue really running around all the vessels. There's also fluid around the liver. And there's also a dilated and potentially obstructed right kidney. But most importantly for this patient is all the sort of soft tissue attenuation material tracking along the vessels in the region of the SMA.
Thank you so much. So in February, the labs demonstrated a bilirubin of 1.9, transaminase elevated at 250, respectively, for AST and ALT. Alk-Phos was 500, CA19-9 was 300. Ultrasound demonstrated intrahepatic ductal dilatation. MRI demonstrates high-grade stenosis. ERCP demonstrates CBD stricture. EUS demonstrates a pancreatic head mass 2 by 1.8 centimeters, and FNA is consistent with the poorly differentiated adenocarcinoma. He then receives 8 cycles of neoadjuvant gem-abraxane or gem-nab-paclitaxel, undergoes a surgical procedure 8 months later with the Whipple procedure with residual moderately differentiated adenocarcinoma, unfortunately with positive margins, extensive lymphovascular invasion, peritoneal invasion, and 14 of 25 lymph nodes positive. YPT2, N2, M1, CA19-9 has decreased now to 30 and is not surprisingly KRAS mutant. I think there's a incorrect date there, but basically it then goes on to say that the patient proceeds to receive 4 cycles of adjuvant FOLFIRINOX, and then the CT scan unfortunately demonstrates retroperitoneal soft tissue concerning for recurrent disease, and now the CA19-9 is elevated back at 250. And I know this case is largely a case about discussion about radiation therapy, but can Dr. Kubi just mention briefly, obviously, impact of this type of his original presentation and how he then went on to surgical resection, and with these findings, what does that mean in regards to this patient's prognosis?
Yeah, thank you, Dr. Ng. The thing that attracts our attention right away with the information we have so far is the really horrible pathology findings, 14 positive lymph nodes, extensive lymphovascular invasion, et cetera. So no major concerns with how this case, at least from the description, was managed up to this point. But once you have this information, and any consideration for any additional surgery is going to be off the table. This is going to be a systemic failure, if anything, from this point forward.
Thank you so much. And then Dr. Benson, what are your thoughts? They proceeded to give him adjuvant FOLFIRINOX for 4 cycles, and yet still he has progression.
Well, unfortunately, although this is a rapid course beginning February, and now we're into October, I think the features that Dr. Kobe mentioned are of enormous concern. And unfortunately, these are individuals who do progress fairly rapidly, and the effects of chemotherapy wane, and the patient has received our most optimal regimens. And so in this setting, there's no standard third-line therapy. And these are individuals where if we have a clinical trial and the patient had a good performance status, that's where we would be at this point. But it's very concerning, this picture of very worrisome histology and rapid progression. But I'm afraid that's what you would predict based on the findings at the time the patient received adjuvant therapy. I think certainly in this case, people would want to give FOLFIRINOX or modified FOLFIRINOX if feasible, but unfortunately, it didn't seem to be adequate.
And Dr. Ng, can I just add one additional thing? This is one case where, again, hindsight is 20/20, but where we might have considered pushing the therapy out to 6 full months of chemotherapy and then considering radiation before going to the OR. But again, without the pre-op imaging and seeing the patient, it's hard to say anything was done different from what we would do.
Yes, very valid point. Dr. Patel, this gentleman who's had 8 cycles of nab-paclitaxel and then adjuvant FOLFIRINOX and now still with progression, what can you offer this person?
Yeah, a very challenging case. I think I'd echo what Dr. Kubi just said. In hindsight being 20/20, we'd love to have given all of the treatments neoadjuvant, including radiation, to try to get to that negative margin. So, I think we talked about the Alliance trial before, but there's another study, the PREOPANC randomized trial, which did include either chemo or chemoradiation prior to surgery in borderline pancreas cancer. And we did find that reduced the rate of margin positive disease. As in most GI cancers, we'd always love to give the radiation before the surgery in locally advanced disease. Now, the question I think that comes to mind to me is really, again, what Dr. Benson and Kubi just mentioned, which is a very high risk of distant progression. From the pathology report in particular, we're seeing M1 disease with periaortic lymph node involvement. This is a common area that we cover with radiation. So I'd certainly make my way over to radiology and sit down with Dr. Siegel to carefully go through this post-operative scan and really look to make sure that we're very clear that there's not distant progression. But in the absence of ostensible metastatic disease seen on the scan, I think you could consider a course of adjuvant chemoradiation here, save for if there's not a clinical trial available. I totally agree with Dr. Benson that if there were a clinical trial, we'd consider that. But the periaortic lymph node chain is typically covered we're eagerly awaiting the results of a trial in this setting. It's called RTOG 0848, where post-operative chemoradiation was given. And that trial in particular has an excellent atlas for radiation oncologists to follow in terms of the post-operative volumes to treat. They're extensive. They include the periaortic lymph node areas, all of the elective lymph node areas, portal, celiac, and SMA, including a margin around the pre-op tumor. So that type of a large volume, I think, is what would be really the only thing that makes sense here. Again, with the chemoradiation approach, with concurrent 5-FU in all likelihood. SBRT in particular would be something that I would not recommend, with this type of a pathology report. But with M1 disease, I think it's controversial, and you could make the case to omit the radiation as well. The only point I'd make is with a growing soft tissue mass in the retroperitoneum, there's also going to be, I think, a palliative benefit to local therapy here, probably in the near future.
Definitely.